Anorexia nervosa is a serious mental health condition. It is an eating disorder in which people attempt to keep their body weight as low as possible.
There are two specific types of anorexia nervosa. Firstly, there is the restricting type. This is in which the individual restricts themselves from eating but does not engage in binging or purging. The second type is binge eating or purging type. This is where the individual makes themselves vomit, uses laxatives, or anything that can be used to purge.
In the US, the lifetime prevalence among adult women was 0.9% and men 0.3%, while in the European study, no cases of anorexia nervosa was found. 90% of cases are in females, while 10% are in males. The incidence of anorexia nervosa in the world is around 8 per 100,000 people a year. Anorexia rarely begins before the age of puberty, and so 90% of cases are diagnosed before the age of 20, while fewer than 10% of all cases occur before the age of 10.
Izzy, I need to talk to you about something really important. Do you think you could meet me for coffee sometime?
Yeah, of course. Meet me in the usual place in 15 minutes.
Okay, see you in a bit. Izzy,
Yeah.
have you noticed anything new about Philip?
Actually, yeah, I was thinking about it, and maybe he just has some weird obsession with sports or school or something.
What do you mean?
Well, like, he's constantly at the gym. He's so obsessed with his fitness, it's insane. And also, he tries insanely hard in school, and he always has top marks.
I mean, I asked him why he's so tired all the time, and he said he just has trouble sleeping. We were so close to him before, like, what's happening to him? He seems to get so irritated when we try and talk to him.
Yeah, honestly, it's like suddenly he has such difficulty interacting with people. It makes no sense.
He's also obsessed with his appearance, like he's always looking at himself in the mirror.
I haven't seen him eat lunch recently.
He's constantly counting calories. Yeah, he might have anorexia. What do we do? I think we should get him to seek help.
Good idea. Let's talk to him tomorrow. Hey, Philip.
What's up? How you doing?
Not much. How are you?
I'm good, yeah.
Haven't seen you in a while.
Yeah, I've been busy with stuff, you know.
So, what's up? What's new?
Been kind of stressed, didn't get much sleep last night, to be honest.
Oh, really?
Yeah, I don't know,
Why?
man. I just couldn't sleep.
Oh, alright. Well, do you guys want to order something?
Yeah,
Yeah.
let's go.
Yeah? This looks so good.
Yeah, I'm so hungry.
Yeah.
Philip, are
So
you not going to
good.
eat?
I'm not feeling hungry today. I slept long, so.
What are you talking about? It's 12 o'clock. You never even wake up till 12 o'clock on a Saturday.
Yeah, you couldn't have already eaten.
No, but like, I could sleep last night, so I'm really tired. I'm not hungry, so sorry. Yeah. Weird. Anyways, yeah, I'm think I'm just gonna go, I'm not hungry.
Philip, sit down. So you know we're studying in psychology?
Anorexia nervosa?
Yeah, you show all the symptoms of someone who might have it, and we're actually really worried about you. You can talk to us about it, you know.
Yeah, we're here for you.
What kind of friends are you?
Philip, wait!
Philip!
Philip! Philip, we're not trying to be mean.
We just want to understand what's going on.
You should really go see your GP or a psychiatrist or something like that.
It's worth it, because you can see if they diagnose you with anorexia, then you can get help.
No, guys, I'm fine, okay?
Please just do it for us. Like, we just want to know that you're okay.
It's really serious. It could have a lot of medical implications.
Okay, I'll do it.
Thank you.
To be diagnosed with anorexia nervosa, you have to meet some of the criteria the DSM-5 outlines, like restricting food intake, fear of gaining weight, problems with body image, and missing 3 menstrual cycles in a row. The GP is trying to diagnose an eating disorder, such as anorexia nervosa. They will ask questions about your weight and eating habits, like, have you lost a lot of weight recently? How do you feel about your weight, and are you concerned about it? To diagnosing anorexia nervosa is checking the person's weight. If someone has anorexia nervosa, their weight is about 15% or more below the average for their age, sex, and height. Other tests are done, like checking your pulse, blood pressure, temperature, and examination of your feet and hands to check for signs of decreases in health. There's a definite and significant difference between subtypes like binge and purge and restrictive subtyping, and so subtyping can be considered essential in proper diagnosis of anorexia nervosa and lead to the proper treatments. The test-retest reliability of diagnosis has a kappa coefficient of 0.95 and an accuracy rate of 0.98, which are both extremely high. Limitations of the diagnosis of anorexia nervosa includes the validity of subtyping, and some concerns the medical community have is, do clinicians use the subtyping scheme appropriately, and do the data support the predictability of the subtyping? Limitation and strong ethical concern can also be the nature of the diagnosis, as many girls might not actually have anorexia nervosa, but just show symptoms.
To this day, it's unknown exactly what causes anorexia. However, there could be 3 factors which all interact. This includes biological, cognitive, and sociocultural factors. Serby offered an evolutionary explanation for anorexia nervosa based on the fact that weight usually comes after the absence of menstruation and that anorexia is most common in girls that have matured early. Dean et al. From 2007 suggested that anorexia could be a cause of OCD or an underlying obsessive-compulsive disorder. So twin studies have been used to estimate to what extent anorexia is due to heritability. A study conducted by Bulik et al. In 2006 gave a heritability estimate of 56%. This suggests there could be a strong genetic component. Cook et al. Summarized a series of brain imaging studies in 2007 which showed a decrease in activity in the parietal cortex in patients with anorexia. The decrease of activity in this part of the brain could be the cause of delusions about weight and shape. Byrne et al. In 1999 provided an explanation that low self-esteem and extreme need for self-control are the main causes of the disorder. It said that individuals with anorexia will use food as a way of expressing their control because it's much easier to control what you eat compared to other things such as schoolwork or physical activity. Brooks' body image distortion hypothesis from 1962 suggests that those with anorexia overestimate their body size, thus they think that they are bigger than they actually are. In most Western societies, on a day-to-day basis, we are exposed to individuals who either are unreasonably thin or have a perfect body type via the media. Et al. In 1996 suggested that there is a social fat phobia. So through this we are taught to despise fat, that we have to be thin, and fat is the enemy. Individuals who develop anorexia are usually the ones who believe these messages and accept them to the greatest extent. Strahan et al. In 2007 offered an explanation that it is not the media that influences women to believe that their body is not the right shape, but rather viewing all these thin women causes women to believe that this is what is acceptable and everyone likes. So by viewing all these images in the media, women rather think, or men as well, rather think that this is what people like, this is what I have to be. Thus they feel more inclined to conform to that social stereotype and that's what they must look like to be liked by others. Another socio-cultural factor in anorexia could be environmental factors such as family and the way in which a child is brought up. Another factor could be abuse, physical or sexual abuse. Olsom et al. In 1993 noted that about 70% of subjects with an eating disorder or psychiatric disorder reported a history of sexual abuse, and about 50% reported a history of both physical and sexual abuse. Another factor in the socio-cultural level of analysis could be the attitudes or prejudice which is given off by society to people who are overweight.
Treatments for anorexia nervosa take an eclectic approach. This means that different forms of treatment and different types of professional help are all used together. It is very rare that a patient will only use one form of specialist or treatment, as it is not very effective in this case. Who treats a patient with anorexia nervosa? Well, first of all, there is the general practitioner, or GP as you may call it. There are specialist counselors, psychiatrists, psychologists, specialist nurses, dietitians, and pediatricians for children or teenagers. Individual therapy uses more than one kind of professional help of any of the following categories: physician, psychotherapist, or dietitian, and there are many more. It is much more beneficial to use this disciplinary team in treating anorexia patients. It is therefore highly recommended that the therapy involves therapists, family, community, and other practitioners of cultural relevance. It is most common to use cognitive behavioral therapy. But there are other therapies such as cognitive analytic therapy, interpersonal therapy, and focal psychodynamic therapy. The patient may also go through behaviorist treatments. Talking about family interventions or family therapy. So, Anorexia will not only affect the individual, it will also affect their family as a whole. In these treatments, the family will discuss how anorexia has affected them as a whole, and they will look at how the individuals may be playing a dysfunctional role within the family and how their eating behaviors maintain this role. They will then try and come up with solutions all together as a family. These interventions may not always include the person who has anorexia. A specific method for family therapy named the Maudsley method, in which parents take responsibility in feeding their son or child and in turn help them improve the child's eating habits. This is effective for children and teenagers, especially if this hasn't become a chronic behavior. Family therapy can also be a good balance in between individual and group therapy. Therefore, learning how to communicate better within the family can help the family as a whole. Lastly, I will be talking about group therapy. Group therapy is very common amongst anorexia patients. It is beneficial for people who live in the hospital as a part of treatment to help them get better, and it is also beneficial for outpatients as it helps to prevent relapse. Therapy is more cost-effective than individual therapy and is beneficial for patients to get to interact with other people who have the same disorder along different stages of the line, which can help provide hope for patients who are early in treatment when they see people who are nearly recovered. It provides reassurance. It also helps their self-esteem as people may help other people, making them feel good about themselves. It is also good as patients may feel pressure from other members of the group, and this may spur recovery. A supporting study for this is Woodside and Kaplan, done in 1994. The aim of this study was to compare the response to intensive daily hospital treatment of male eating disorder patients to female eating disorder patients. What they did was put males and females together in group therapy that specifically targeted negative and destructive attitudes towards food and eating. They used a CBT approach similar to the one that Bowers made in 2002, but they used this for group therapy instead of individual therapy. They used a range of behavioral criteria and psychometric measures at both arrival and leaving. The findings of this study were that both males and females showed improvement on the eating attitudes test. To be more specific, it was found that males had similar responses to females on admission and discharge, but they had slightly lower scores on eating attitudes test, eating disorders inventory than females did. They concluded that males will not respond very differently to females and therefore can be in group therapy sessions where most of the patients are females. The study therefore supports that group CBT is effective in treatment. However, there are two significant problems with group therapy that have been identified in a study done by Polivy in 1981. Firstly, patients may create a new identity based on their group membership, maybe because they have conformed. So this therefore means that the patient also needs independent therapy. Second of all, patients may teach other patients new strategies to avoid eating, even if this is unintentional. This means that group therapy may undermine individual progress. There are also medicinal treatments that go along with these psychological treatments. There is limited evidence that these medicines are effective on their own, but they can help in preventing relapses, which can be shown in a study by Holtkamp et al. In 2005. Biomedical therapy firstly tries to make sure that weight gains are made. This can be done by attaching the patient to a drip, for example. After this, through individual therapies, the patient is encouraged to eat normally. It is also sometimes said that for certain people, anorexia is a form of anxiety disorder or depression disorder. So for these people, using medication can aid in preventing the emotional state that comes before a relapse, in turn preventing the relapse itself. These medications only alleviate the symptoms of the disorder, therefore it is beneficial for the patient to take an eclectic approach and use a number of different types of therapists and medicine.